Hello, everyone, and welcome to the next installment of Risfeld Neurology Education, a not for profit project exploring all areas of clinical neurology. I'm your host, Tom Risfeld, a neurologist, epileptologist, and neurophysiologist and neuromuscular specialist, and also a physician, philosopher, and bioethicist. Find more neurology content at our website, rneurologyeducation.org. That's R as in the letter R, or email us at contact@rneurologyeducation.org to get in touch. We upload videos to YouTube and audio podcasts to wherever you get your podcasts with the domain rneurologyeducation, and you can find us on social media platforms at the same domain, apart from X, which is at rneuroeducation. And before we get into it, a legal disclaimer: the content in this episode and in the Risfeld Neurology Education Project as a whole is for educational purposes only. So, what are we talking about today? This is the first episode in the clinical method series, and we're going to be focusing on history taking. So, why is good history taking so important? Well, you may have heard of the 70-20-10 rule, which dictates that when making a diagnosis, 70% comes from the history, 20% from the examination, and 10% from investigations. It might not sound sexy, but it is completely true. And if there's one episode in this entire project or one skill to get really, really good at, which you're going to be able to employ in every area of neurology and every area of your clinical practice, even if that's beyond neurology, it's going to be having good history taking skills. As the old adage goes, more harm is done by not asking than by not knowing. This really is the bedrock of neurology, and it's particularly true in neurology of all specialty areas in medicine. This is because there are fewer objective biomarkers in neurology than in some other specialties. For example, you can essentially get an HbA1c to more or less make a diagnosis of diabetes mellitus, but you can't do that in Parkinson's disease, which depends on making a firm clinical diagnosis, supplemented by investigation findings. And furthermore, there is a key importance of obtaining a detailed semiology, particularly for epilepsy and for headache disorders, along with really pinning down the time course of the symptomatology in all subspecialties in neurology, because this is essentially narrowing down the etiological differential diagnosis. Good history taking is required to tailor a sensible, stepwise approach to investigations, and it's therefore time and cost efficient, and it avoids inappropriate incidentalomas. So they are, you do a MRI when it wasn't really indicated in the first place, and then you find a lesion, which is probably a benign meningioma, but maybe it's not, and then it causes considerable anxiety and potentially iatrogenic harm from overdiagnosis and overtreatment if an excessive MRI wasn't actually indicated in the first place, if someone had just taken a history and made a clinical diagnosis or targeted their investigations appropriately. It's also required to tailor the neurological examination, because as we'll show, there's a foundational neurologic examination which covers most of your bases, but there are subspecialty or more specific aspects of the neurologic examination which is only used when it's indicated. For example, you're not going to perform a Dix Hall pipe maneuver on a patient with clear cardiogenic syncope as opposed to vertigo. And an even more excessive example would be you're not going to be testing for fatigable shoulder abduction weakness as part of a neuromuscular junction myasthenia gravis screen in a patient with a completely unrelated neurologic presentation that has nothing to do with the neuromuscular system. Maybe they presented with a seizure or a headache. It's also essential for developing good therapeutic relationships So, establishing trust and rapport with the patient and having a good conversation and eliciting a good history can be therapeutic in and of itself because it makes patients feel listened to and cared for. And especially when they don't feel rushed, they feel like that you're taking them seriously and you're giving them your full attention. And that can be beneficial in and of itself. So, what are my broad tips for optimal history taking? Firstly, you need to be systematic and thorough. A good example is don't forget to ask about recreational drugs. Even in an 80-year-old from a nursing home, I have been surprised more than once, and you will be too. Secondly, ask open questions first and then move on to asking your closed questions. The patient will often effectively tell you the diagnosis in the first 5 minutes of the consultation if you just ask a single open question and then just let them talk. So if you say, "What's your main concern?" and you just let them talk for 5 minutes, at the end of that 5 minute dialogue, half the time, or maybe not half the time, but a considerable portion of the time, you already basically know what the diagnosis is just after that step. Conversely, closed questions are almost always necessary to elicit key positive and negative features regarding the differential diagnosis. So you ask your initial open question or questions, understand what direction you're heading in, but then you do need to ask key yes or no answer questions to make one potential differential diagnosis more and more and more likely, and all the other ones less and less and less likely. Thirdly, it's really, 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 really important to avoid leading questions, and I can't emphasize this strongly enough. And I'll give a few examples here. Compare the following, asking, how long did it take from the beginning of your headache until it reached its maximum severity to did the headache come on like a thunderclap? Because if you ask the latter, the patient might say, "Oh, yeah, it did come on like a thunderclap." But if you ask it in the first way, they might say, "Oh, it took 5 or 10 minutes," which is not a thunderclap headache. And that fundamentally shifts the gameposts as to what we're dealing with here. Are we dealing with a thunderclap headache? Are we dealing with a subarachnoid hemorrhage, reversible cerebral vasoconstriction syndrome, RCVS? Or are we dealing with a migraine? Or did it take a month to reach its maximal severity? Are we dealing with a brain tumor? Another example from beyond neurology, which came up a lot when I was a basic physician trainee doing cardiology, is comparing the question, "What's the nature or the character of your chest pain?" with the question, "So, does it feel like there's an elephant sitting on your chest?" Because when you ask the patient the second option, they'll often say, "Yeah, it does feel like there's an elephant sitting on my chest." And so you say, "Gosh, this is typical cardiac chest pain. Let's open the cath lab quickly. Let's load them with aspirin and clopidogrel." But if you'd asked it in the first way, maybe they would describe something that actually really didn't sound that much like typical cardiac chest pain. Some other points. Avoid making a premature diagnosis in your head and then leading the patient towards that diagnosis with your questions whilst ignoring alternative possibilities. In other words, avoid falling into the trap of a confirmation bias. An example of this would be assuming that a headache in a patient with a known migraine disorder is just another migraine, without considering the possibility of a secondary headache syndrome on this occasion. Or similarly, assuming that a presentation in a patient with a known diagnosis of functional neurological disorder, FND, or schizophrenia, has symptoms which are psychologically based without considering the possibility that the current symptoms may actually be attributable to an organic cause. Also, it's really, really important to confirm what a patient actually means when they use terminology, especially technical terminology. In particular, you always have to clarify what someone means when they use the word dizziness or vertigo. Do they mean they feel lightheaded, pre-syncopal? Or is it actually vertigo? Or is it more of a disequilibrium, poor balance, which may well could be neurological but might not be? Another example is always confirm what someone means when they say a grand mal seizure, because of course this is old terminology that we don't use anymore, but lots of patients, and some clinicians still do use that terminology. So we need to establish, does that mean that they had a true generalized tonic-clonic seizure, or was it a focal to bilateral tonic-clonic seizure, or some other kind of seizure, or was it not a seizure at all? Maybe it was a seizure mimic. And another example, which comes up in epilepsy a lot, is always confirm what someone means when they say déjà vu. So, are they actually referring to a true déjà vu, so a feeling of familiarity despite being in an unfamiliar time or place, which can be suggestive, not diagnostic, but suggestive that it's an epileptic aura, typical of focal mesial temporal lobe epilepsy? Or do they use the word déjà vu, but then they describe some less helpful, less specific psychic phenomena? So let's move on to the components of the history, and firstly, how do you order them? There are two main approaches to this, two main options. The first option is to start with the past medical history and all the other aspects of the history, and then coming back to the history of the presenting complaint towards the end of the history. Or the second option is to start with the history of the presenting complaint and then move on to everything else. I was taught to adopt the second option in medical school, but I have recently changed to the first option in most circumstances. But this really is situation specific, and it's important to understand the situations in which each approach is more appropriate. So, in a medical emergency environment, so at a stroke call or treating a patient with status epilepticus in the emergency department, or treating a patient with any host of non-neurological emergency, the second option is much more appropriate. So starting with the symptoms, quickly figuring out what's going on, how am I going to intervene with this emergency in front of me, and then sorting out everything else. Usually it is helpful to have a one-liner head start on their background, however, so think about just how much more helpful it is if you're told, I've got a right-handed 75-year-old male with unanticoagulated atrial fibrillation who was discharged for a left middle cerebral artery ischemic stroke 3 days ago, and they represent today with similar mixed dysphasia and right hemiparesis. So that's what you're told upfront, versus here's a patient with mixed dysphasia and right hemiparesis. There's a big difference there. Conversely, if you're in a non-emergency scenario, i.e. a routine inpatient admission ward round or essentially every outpatient clinic consultation, I find the approach starting with the background so that you understand the context in which the symptoms arise and then going into the symptoms is the better approach because it really contextualizes and guides the whole encounter. So, how are we going to actually group together the components of the history? There's lots of different ways to do this. You'll read in different books and hear from different people different ways to group them. The way I like to do it is to remember that there are always 5 key components in addition to someone's basic demographic factors like their age, their gender, and their handedness in neurology. So what are the 5 factors? There's, as we've just mentioned, the history of the presenting complaint and systems review. Some people distinguish the history of the presenting illness from the history of the presenting complaint, but I don't find this a particularly helpful distinction most of the time, although there is some virtue to it, and I'll come to that shortly. Also, some people perform the systems review separately towards the end of the history, but I don't like doing this because when you're eliciting the history of the presenting complaint, you're asking about symptoms anyway, so I like to take the history of the presenting complaint and do the systems review together. The second aspect is the past medical history. The third is the family history. The fourth is medications and allergies. Don't forget allergies. And fifthly is the psychosocial history. Occasionally, there are other specific additional sections depending on the clinical presentation. And a good example would be in epilepsy. So if you're seeing a seizure or an epilepsy patient, there's this epilepsy risk factors section that you also need to elicit. And for those who are interested, that consists of 4 subpoints. So did the patient have a normal pregnancy, birth, and early childhood developmental milestone attainment? Were there any pediatric febrile convulsions? Has there been any previous encephalitis or meningitis? And have there been any previous significant head injuries or concussions? So let's look at each section in turn now. History of presenting complaint and systems review. I like to adopt the Socrates approach for taking a pain history, and you've probably heard of this. So, site, onset, character or nature, radiation, alleviating factors, timing, exacerbating factors, and severity. Some people use the A for associated symptoms instead, but I cover this in my systems review. I do see a lot of senior and experienced clinicians skipping a lot of the above steps, but this is often to their peril. No one is too good for Socrates. Every aspect of Socrates is essential, and you don't really know what someone's pain is like if you don't know all the aspects of Socrates. One thing which is perhaps not quite as appreciated is that you can, or at least I like to, apply this approach to practically every other symptom as well, not just pain, omitting the questions which are not relevant in the non-pain context. That is, knowing what is meant by the description of the symptom, whatever that symptom may be, how quickly it first came on, when it came on, what the temporal pattern of the symptom has been, what makes the symptom better or worse, how bad is the symptom, what other accompanying symptoms are there. These factors are always important for every symptom, and it tells you essentially everything that you need to know about that symptom. So you only have to remember one thing, one word, Socrates, and then you can elicit a history for every single symptom. You then need to go through this approach for every symptom that the patient has. Sometimes patients might just have one symptom, so it's easy. But if a patient has 2 symptoms or 3 symptoms, then you do need to take the time to unpack each of their symptoms. And patients don't always match the textbooks. Often there are 2 symptoms or 3 symptoms or 5 symptoms, and it's by getting all of that information and bringing it together that you can then form a provisional diagnosis and a differential diagnosis that requires consideration. The reason that some people distinguish, at least as I understand it, the history of the presenting illness from the history of the presenting complaint is to identify the main symptom from other secondary or supplementary symptoms to know what to focus on and what to place more diagnostic weight on. And this approach does have some merit. So, for example, when a patient has multiple symptoms, it's important to know which one or which couple of symptoms are the most significant to the patient, especially if they have 5 or 10 symptoms. And there are inevitably the occasional patient who seems to have almost every single symptom listed in Harrison's, in which case focusing your time and your energy on the handful of most significant symptoms is important to do. Otherwise, you completely get lost in the forest and you end up focusing on their pinky toe pain, which was the 9th symptom that they listed, rather than their chest pain or their dyspnea or their tremor or their loss of consciousness, which was really clearly the more important symptom. And it's why they've come into hospital or why they've come in to see you in the outpatient setting. On the other hand, sometimes the patient might present with and be concerned with one symptom, but you might know with your medical knowledge that some other symptom that they have brushed over is actually far more significant. To use a bit of a trivial example, they might be concerned about their hearing, and you know that that's actually just because they've got earwax. It's not because there's some underlying sensorineural deafness, but they might not have realized the significance of their significant unintentional weight loss and their unexplained early morning headaches. So the systems review. This is then a rapid fire screen of closed questions framed in terms of receiving a yes or no answer. And I separate this into 2 parts. Firstly, I do a neurologic systems review, and I like to think about these key neurologic symptoms to routinely screen for based on 3 of the major categories of neurologic diseases. So symptoms that could be consistent with stroke, symptoms that could be consistent with epilepsy, and symptoms regarding headaches. And that's going to address most of the bases most of the time. So I say, have you had any? And then regarding stroke symptoms, I ask, have you had any weakness or sensory loss in the face, arm, or leg? Any slurred speech or difficulty understanding others or finding the words to form sentences? Any loss of vision? Regarding epilepsy-related questions, I ask, have you had any instances of impaired levels of consciousness or losses of consciousness, any involuntary shaking movements, any abnormal sensations in the face or in an arm or a leg? And regarding headache-like questions, I ask, have you had any headaches or neck stiffness, any flashes or sparkles in your vision, any other funny symptoms? And I find that some of these questions can be combined. So, for instance, you can ask about positive and negative somatosensory and special sensory symptoms at the same time to address some of the stroke and some of the headache and some of the epilepsy style questions and save a bit of time. So, I'll do that neurologic systems review for every patient that I see. Then, depending on the clinical context, there are additional neurologic symptoms that you need to elicit based on what the context is. So, in the epilepsy context, you need to exclude focal auras. So, you need to ask about motor, somatic sensory, and special sensory auras such as visual, olfactory, gustatory, oral, epigastric, deja vu, and emotional and fear auras. And when eliciting the semiology of an episode, you need to exclude any tonic phase, an ictal cry, a clonic phase, color changes, apneas, oral throttling, a lateral tongue bite, incontinence, although acknowledging that this doesn't really discriminate a seizure from syncope, any postictal period, and also ask about any potentially functional features, so back arching, a stopping and starting cadence, asynchrony to the movements, etc. Conversely, in a Parkinson's disease context, some of the extra questions you need to ask are to exclude any bradykinesia of gait or other movements, rigidity, tremor, postural instability, autonomic instability, constipation, hypoosmia or anosmia, REM sleep behavior disorder, etc. In the multiple sclerosis context, you need to ask about previous clinically isolated syndromes, for example, symptoms of loss of color vision or visual impairment that could be consistent with optic neuritis or painful eye movements. Questions regarding Lemaitre's and Uthoff's phenomena, any myelopathy symptoms such as the typical MS hug, also they call it, and any bowel or bladder or sexual dysfunction, etc. In the myopathy context, you need to ask questions about post-exertional or temperature-related muscle dysfunction, myoglobinuria, consistent with rhabdomyolysis, and you also need to ask whether motor milestones were reached normally and whether they kept up with their peers at school, albeit not being a symptom per se. And this is obviously not an exhaustive list, and we'll go into more detail in each of the episodes addressing the specific conditions. But I've given these examples to give you the idea of the kinds of additional targeted questions that are required contingent on the clinical context. Knowledge of the specific questions to ask comes with a knowledge of the diseases that occupy the differential diagnosis, because there may and often are some key discriminatory questions that you need to ask to distinguish the two leading differential diagnoses. Screening for depression is also essential in most, if not all, of the examples that are provided above, but I do this in the social history. The second part of the systems review is a general systems review. This is a top-to-tail approach addressing all of the other organ systems. Previously, I used to literally rattle off this long spiel, which I will tell you shortly, and I can say in my sleep. However, I'm increasingly coming to the appreciation that you may not have time to do this in all subspecialty outpatient settings. But I do think it's important for admissions and in the inpatient setting, because in that setting you have more undifferentiated patients. So you might have a patient who has a headache, but maybe they've got a urinary tract infection as well, and that could be just as significant to the patient. So you do need to do the general systems review. Whereas in the outpatient setting, you will burn out and go crazy if you take a full general systems review on every patient that you see. You need to focus on the area that the patient's been referred to you for. So what's the spiel? I'll just say it verbatim. I'm going to ask you about all of the other symptoms in the book now to be thorough, but please say no if you don't have these symptoms so that I'm not led down the wrong path. You haven't had any fevers, night sweats, or unintentional weight loss. no sore throat, runny nose, or sore ears, no chest pain, shortness of breath, cough, or palpitations, no abdominal pain, nausea, or vomiting, no constipation or diarrhea, no burning or stinging when you urinate, or urinating more or less often than usual, no rashes or ulcers, and no suddenly sore muscles, bones, or joints. Now, the way that I've phrased the spiel may seem to contradict the no leading questions rule that I spoke about earlier, but it's very deliberate. I've learned from experience over the last decade that without the please say no if you don't have these prompt at the beginning, and without framing every question in the negative, I found that patients are just far, far too likely to say yes to almost every single question you ask them, which then makes the exercise as a whole almost completely useless because it doesn't actually discriminate between genuine significant symptoms and those which are insignificant and are just brought on through a recall bias or a bias of wanting to please the doctor by answering in the affirmative. And it's also just completely exhausting, and it makes clinical encounters take an infeasible length of time. So that's quite important. I really would suggest that when you are taking this general systems review, that you frame it in the negative. And then that means that when the patient does say, oh, actually, yes, I have had this symptom or that symptom, you then know that it's important and significant, as opposed to if they just said yes to all 20 questions and then you have no idea what to focus on. Regarding the musculoskeletal component with the muscles, bones, and joints, I say it's suddenly sore beforehand to try and exclude patients who have mild chronic back pain for decades, because you don't need to hear about that every time you see a patient, provided that it's irrelevant to the clinical encounter, but that's not always going to be the case. So if someone comes in with lower limb symptoms or back pain or genitourinary symptoms and you're considering a myelopathy, an acute cord syndrome, a conus medullaris syndrome, a cauda equina syndrome, obviously you need to really ask about those questions in detail, and you don't just care about acute back pain, you care about any back pain. Okay, let's move on now to the more chronic aspects of the history. So the past medical history. The tips I would give here is to prioritize and list the conditions which are the most serious and the most important and the most relevant first, and then everything else at the bottom. So, for example, whilst the previous appendectomy may be the most important comorbidity to the general surgeon when the patient presents to the emergency department with abdominal pain, the atrial fibrillation and the hypertension are much more important to the neurologist when the patient presents with dysphasia and right hemiparesis. I would also recommend grouping conditions together where possible. For example, I'd put the diabetes mellitus, the hypertension, the dyslipidemia, and the obesity one after each other, or you could put them on a single line as a single item, such as metabolic syndrome with diabetes, hypertension, dyslipidemia, and obesity, just to help you conceptualize the patient more clearly. And it also enhances your communication with colleagues. And I'd recommend putting the appendectomy and the cholecystectomy and the inguinal hernia one after each other lower down on the list. I then specifically ask about very important conditions in the particular clinical context if not volunteered by the patient. So, for example, if they come in with dysphasia and right hemiparesis, as mentioned above, and they don't volunteer any previous strokes, I'll explicitly say, have you previously had a stroke? Have you had any irregular or funny heart rhythms in the past? And this really is contingent on whatever the clinical context is. Previous investigation results can be included here. So, for instance, if someone has coronary artery disease and they had an angiogram a week ago and they had 70% stenosis in their left anterior descending artery and they had a stent put in, you could include those details in the past medical history. However, I do like to include the neurologic investigations relevant to the neurologic presentation later on in the investigation section, although that's really just a matter of personal preference. Moving now to the family history. So this should focus on the neurologic family history and on the family history of other symptoms that could still be relevant to the diagnosis or differential diagnosis. So, for instance, a cardiac family history is still relevant to a patient with an undifferentiated loss of consciousness that could still be a seizure or a syncope. And often a rheumatological or oncological family history will be relevant for undifferentiated multisystem diseases that can have neurological involvement, for example, systemic lupus erythematosus, or non-neurological malignancies that can metastasize to the brain. Drawing a pedigree to hint at an inheritance pattern can help, particularly if a genetic diagnosis is being considered. And I would advise against trying to elicit a family history for every condition in every body system, because that's unlikely to be helpful and will not be time efficient. Moving now to medications and allergies. Again, please prioritize these and group them together. And in particular, put your anticoagulants and your antiplatelets at the top of the list. There is nothing more frustrating than seeing a patient with 17 medications and they've presented with an intracerebral hemorrhage and their rivaroxaban is the 16th medication on the list. It's quite frustrating. I do understand that sometimes it's in alphabetical order. That's also understandable, and at least that's in some form of order. But I really do think that having medications grouped together is prudent. And it's also context dependent. If someone's presenting with a seizure or epilepsy, you want all their anti-seizure medications together and at the top, not mixed in and down the bottom. Don't forget to ask about adherence and side effects. And this is especially important in epilepsy because so often a seizure might be the product of medication non-adherence, or there may be really quite significant side effects which are limiting the ability of the patient to continue taking the medication and contributing to morbidity. And often side effects lead to non-adherence. And it's also important to consider and discuss strategies for improving adherence. So, for example, is the patient using a pill organizing system such as a Webster Pack or a Dosette box? Are there any smartphone pill reminder alarm systems or apps that are being utilized? Is the patient keeping their medications on the bedside table or next to their toothbrush so they remember to take them in the morning and the evening? Don't forget to ask about previous medications trialed when relevant. And again, this is especially important in epilepsy. You don't want to see a patient with a seizure, try and think, how am I going to escalate their treatment, and think, oh, I'm going to be smart and I'm going to add in perampanel. If you didn't know that someone else tried perampanel 6 months ago and it wasn't tolerated, so it was stopped. And also, don't forget to ask about the nature of allergies. So, for example, there's a very big difference between lamotrigine causing mild fatigue and lamotrigine causing a whole body blistering rash with mucosal involvement. Very different, worlds apart. Now, let's move on to the last component of the history, which is the psychosocial history. I like to break this down into the following sections. Smoking. Always include previous smoking, calculate the pack years, and also think about non-cigarette based products, including cigars, pipes, and vapes. So I always ask, do you or have you ever smoked cigarettes or other nicotine products? Secondly, alcohol. Thirdly, other recreational drugs. And as I mentioned at the beginning of the episode, never, ever, ever assume based on someone's demographics or their appearance that they do or don't consume recreational drugs. You always just have to ask. And I have had people laugh at me, other colleagues laugh at me when I ask patients who don't look like they take recreational drugs if they take recreational drugs. And then I've got to quietly smile when it turns out that that patient was an avid drug user. So it's always important. Also, don't forget to ask about nitrous oxide, which is a up and coming recreational drug, which we're seeing a lot of use of in Australia and I presume elsewhere in the world. And it's very important neurologically, especially for subacute combined degeneration of the cord, causing a posterior cord predominant myelopathy presentation, which can be very, very disabling, and also a peripheral neuropathy in the context of nitric oxide abuse. And nitrous oxide, I should say, can be easily acquired over the internet, and some people don't really consider it to be a recreational drug if you don't specifically ask about it. Then you need to ask about living arrangements and the patient's family setup, their education and occupation, whether they drive or not, and do not forget that, especially if it's anything to do with epilepsy or seizures or stroke. Then you need to ask about the patient's mental health, and you need to specifically ask whether there are any significant depressed thoughts or any suicidal thoughts or behaviors or attempts. And it may or may not also be relevant to do a brief psychosis and manic disorder screen. then you need to ask what the impact of the symptoms or the disease is on a person's life, and this is especially important in epilepsy. It's usually also important to ask about a patient's function and activities of daily living, whether they have home carers, what their level of mobility and gait is, whether there have been any falls, although this can be omitted for an obviously young and independent patient. Sometimes it's relevant to ask about travel, especially if you're considering an infectious disease of the nervous system. Rarely it can be relevant to ask about pets and animal exposures, etc., although this is mainly relevant in the infectious diseases world and in respiratory medicine, although it may occasionally be relevant in neurologic diseases. Lastly, in the psychosocial history, don't forget about the sexual history. It's not always necessary, but most of the time, or at least a lot of the time, it is, and it's very important. And the sexual history basically includes assessing someone's pregnancy status or their chance of pregnancy, what contraception they're taking, if any, and also wondering about sexually transmitted infections, STIs, and in neurology, that's especially HIV/AIDS and syphilis, amongst others. Regarding the pregnancy and contraception, obviously this is important, especially when we're considering prescribing various medications that we use in neurology. And I can say that in the last 6 months, I've diagnosed 2 patients with unintended pregnancies that the patient was unaware of. And it was quite significant because both patients had had nuclear medicine imaging performed, so either PET scans or SPECT scans, in the context of an epilepsy pre-surgical evaluation. And it's hard because sometimes you just can't know and you can't be sure. It's not enough always just to ask the patient, are you pregnant or could you be pregnant? Because both of those patients said no, but then when you dive a little deeper, actually there was unprotected sexual intercourse since the last period, or in the second case, there was actually a surgical contraception method in the patient's partner which had failed and they didn't know about it. So always think about pregnancy in a female of reproductive age and also ask about contraception. This is important in epilepsy and other areas of neurology, and it's also important to think about folic acid supplementation if someone has epilepsy, for example, and they are not using a reliable form of contraception and they're on anti-seizure medications, or even if they're not, it's always important to think about folic acid supplementation. The dosing is a little bit controversial, and we can discuss that in a later episode. And then regarding STIs, and in particular the risk of HIV/AIDS and syphilis, and therefore the risk of other immunosuppressive infections. It's always important to consider this, especially amongst men who have sex with men, although, of course, it can also be transmitted heterosexually or as a bloodborne virus through needle sharing in particular. So, when is it okay to cut corners? I've been through a lot. We're all pushed for time. We've all got to see a lot of patients, and we never have enough time to do it. So, it's important to have a good feel for when you can cut corners and when you can't. So, what my recommendation is I really like to take the full comprehensive history the first time that I meet a patient. So, that's when I'm admitting them, or when I'm seeing them on the admitting ward round for inpatients, or for my initial appointment with an outpatient. But there are a few exceptions, and they're emergencies, especially stroke calls, when you have a completely different approach, which will be discussed in another episode. Then in subsequent reviews, so on subsequent inpatient ward rounds or follow-up outpatient appointments, you can be much faster, and you really just need to focus on what changes have arisen since the time of the previous review, which is basically what changes have there been in regards to new or progressive symptoms? Have there been improvements with treatment, side effects from treatment? Or if lots of time has elapsed between reviews, have there been any new treatments or diagnoses that have been started or made by other clinicians that you didn't know about? And that's it for this episode. There was quite a lot of information there, but hopefully this has helped your ability to take less biased, more comprehensive, and more helpful histories, and will make you a much better diagnostician and a better clinician and a better neurologist. So thanks for tuning in. Please like, comment, and subscribe. Visit our website, ourneurologyeducation.org, for all our media formats and additional content. Find our video presentations on YouTube and our audio podcasts wherever you listen to your podcasts, and join us on your preferred social media platforms. And email us on contact@ourneurologyeducation.org for any questions or queries, or to subscribe for updates in terms of new content being released. From cortex to curiosity, this has been Risfeld Neurology Education. Until next time, keep calm and synapse on.